within that patient pathway is just the patient counselling that occurs. So things like fertility preservation, if they're premenopausal, talking about potential side effects. We may have input through our allied health professional colleagues, say physiotherapists, looking at prehabilitation, and then obviously talking about the different treatment options. And they do vary quite significantly in terms of maybe the management that's available and the eligibility. So we might see breast conserving surgery where patients might have a lumpectomy and then a sentinel lymph node biopsy. They may decide to go for a mastectomy with or without immediate reconstruction. And I think, again, that's a decision that patients have to be talked to and kind of supported in making that decision, and potentially with the addition of axillary lymph node dissection as well. And then we start to think about some of the adjuvant therapies. So post-surgery, they may have radiotherapy, and the radiotherapy itself may be to the entire breast tissue if they've had breast conserving surgery, or it may be to the chest wall if they've had mastectomy, and also if they have high features of risk for spread. We might also treat the supraclavicular fossa nodes and the axillary lymph nodes as well. And sometimes we may even actually irradiate the internal mammary chain as well. So regional nodal irradiation as well that we might see. Chemotherapy, again, it depends on the regime specific to the histopathology and the stage and the grade, and then endocrine therapy as well if it is estrogen positive, and that typically is tamoxifen if they're premenopausal, or the aromatase inhibitors if they're postmenopausal. Also as well, thinking about, are they hormone receptive? So I kind of list this off as it's like, oh, that is just what patients have to go through. So from your perspective, you're so early on in the pathway, but there are so many decisions that patients are typically presented with. And I think sometimes when you are seeing them at your stage, kind of talking about some of the pathway may really help patients in identifying what they've got to go through, and preparing them as informally as you possibly can do, and thinking about, you know, how can you start to sow the seeds. I think it would be negligent of me as well if I didn't also talk about metastatic disease management as well. And I think that's really important to consider, that sometimes for some of these patients, they may be diagnosed at quite a late stage, and therefore they may already have metastatic spread. And it's about thinking, how can we use surgery, immunotherapy and radiotherapy to kind of help ease any symptoms. And palliative radiotherapy is really successful, which I'll talk about in a little bit more detail later on. But I think supportive care and management across the entirety of the patient pathway is really, really important. And I think that follow-up, absolutely, when patients are going for routine mammograms post-treatment, is really important to consider, just from a psychological perspective. In radiotherapy, we typically find that patients will go rapidly through the patient pathway, and then it's actually during radiotherapy, if that's their last treatment, where they will struggle significantly with the psychological impact of a cancer diagnosis. And I think that that is typically because they are having time to reflect. They're lying in a room on their own, being irradiated. And I think, unfortunately, because of some of the wait times as well, they are waiting for these treatments, and it gives them time to kind of reflect on what they've gone through. And we typically see that kind of psychological response to what patients have actually gone through. So in terms of kind of radiotherapy, where does it even come from? What is it? Well, I'd like to think you all have your basic X-ray knowledge that I don't have to go through with you. But in terms of radiotherapy, it has evolved hugely, even since I qualified, let alone when X-rays were first developed and used clinically to treat cancer patients. But you can just see from some of the earlier photos there, you know, some of the earlier LINACs, just the range of movement was very arbitrary. The linear accelerator is what you can see here in these diagrams. would literally just rotate around a patient, and we would have lots of lead blocks that we would literally lift up. Manual handling was not a thing back then, but you would literally put a lead block over where the x-rays were coming out of, and that would shield your normal healthy tissue. And we use significantly higher doses of radiation compared to mammography. So typically our patients are receiving 25 gray worth of radiation. So it kind of puts into context a little bit about just how powerful the x-rays are that we're utilising. You'll see from the image there where we've got this little light with all these leaves. These are called multi-leaf collimators, and they have revolutionized how we are able to actually modulate our radiotherapy treatments. So what happens is they will actually conform to the shape and size of the tumor, but they can also move in and out. When the machine is actually delivering the x-rays, it will move in and out of the radiotherapy treatment field, and it would allow you then to adjust the dose that certain parts of the tumor or certain parts of the area are actually receiving. So you can kind of see from this radiotherapy treatment plan here how the dose can conform to a variety of different shapes. And I've got some nice ones of breast and chest wall coming up. In the last 5 years, we've seen a radical change in radiotherapy and radiotherapy techniques, but also just some of the equipment that we use. So you may have heard of proton beam therapy, and there are some research studies that are being undertaken in London at the moment around the use of proton beams specifically for the treatment of breast cancer. It's a treatment that they routinely do in America, and the skeptical Joe McNamara will say that that's probably because it's more expensive and they can charge more. I don't know, but in terms of kind of the research and the evidence base for using proton therapy over our standard external beam radiotherapy, it currently isn't there. So it's just one to watch. It'll be interesting to see what the long-term follow-up for proton therapy looks like. You can also see in these images, this is a cyber knife. So it's literally a robotic arm, very much like, have you ever seen those factory videos where you see the cars being put together? It works in more or less exactly the same way. And when a patient goes in for surgery, they would put some implants into the tumour. And because the tumours move, specifically say a lung tumour, what will happen is the machine will detect where the tumour is at any given point, and it will just switch on. I have to say they're going out of fashion a little bit. I don't know whether the eligibility criteria was quite strict for the use of CyberKnife. They're not in every radiotherapy department. They are very expensive. And so it'll be interesting to see where that piece of technology goes. We also have the amazing MR Linac. If I was to put shares on anything, I'd definitely put it in the MR Linac. I'm sure I'm not going to make much money though. We are healthcare professionals after all. But the MR Linac will absolutely revolutionise radiotherapy if we can fund them to be used in radiotherapy, just because of the imaging quality that we get. So something that we could definitely look at doing through MR is something called adaptive radiotherapy. And that's where we essentially get an image on a daily basis where we can then manipulate where we're treating, and in real live time we can see tumours shrinking and adapt on a daily basis so that we limit the dose to our normal healthy tissues. How radiotherapy works is typically you would come for treatment every single day, and you would typically have weekends off unless you had an emergency case where potentially, I don't know, a spinal cord compression or an SVCO. That's potentially where you might see patients on a weekend, but typically the radiotherapy departments operate between the hours of 8 till 6 because of the wait times at the moment. Lots of departments are working until 9-10 o'clock at night and doing shift patterns, but you know, hopefully in the good old days we'll get back to. But saying that, I've worked in Hong Kong and they did 24/7 radiotherapy, and everyone having radiotherapy would be an inpatient, and you'd go and get them from the ward and bring them down. So wouldn't that be amazing that you could have your treatment at any time 24/7? I'm not sure the workforce would agree, but from a patient perspective, think of the throughput, it would be pretty special. And then last but not least, we have the gamma knife, which is this image here. with a lecture on it. And gamma knife is something that traditionally is used to treat brain metastases. So we know that breast cancer has a propensity to then spread to the brain. And if for any reason we were to identify metastatic spread, then the gamma knife is the piece of kit that we would want. Now, we can do whole brain radiotherapy. But again, from a personal perspective, if I was a breast cancer patient, I would advocate for myself and try and have gamma knife over whole brain radiotherapy, just because it is much more targeted and your brain is not receiving low doses of radiation across the entire brain. So something to kind of, again, support patients with, because if you're seeing them through that follow-up period, there may be times where actually, you know, they're going for their breast screening, but they also know that they have metastatic spread at that stage, and that could be a conversation that you have with them. You know, really advocate for it. It's not something that is available in every single radiotherapy department. So and some oncologists just don't know enough about gamma knife, so they don't necessarily kind of refer patients. So we're always shouting about it to our patients as much as we possibly can do, and again, kind of giving them information about that. So radiotherapy is used in about 40% of all cancer curative intent, and we have the potential to actually treat many more patients than that. Actually, the statistics look like 50%, but unfortunately, just because of the referral and surgery, maybe being more accessible than radiotherapy, it's maybe not necessarily utilised to its full capacity, but it is a cheap treatment, especially when you compare it to chemotherapy and immunotherapy. So Radiotherapy UK do a lot of work in trying to raise the profile of radiotherapy as a cancer treatment, and petition quite a lot government to invest more heavily in it. But yeah, compared to chemotherapy and immunotherapy, radiotherapy is definitely a winner, and works highly effectively at treating cancer. Therapeutic radiographers, as you will find out tonight, are the only profession that can deliver radiotherapy. However, we are seeing diagnostic radiographers infiltrating the radiotherapy department, which we are very happy about, because of the development of the MR-Linac. And we don't typically at undergraduate level have lots of MR training. So definitely that could be an area where diagnostic radiographers and therapeutic radiographers work more together within that setting. So how does it work? Well, take you back to your pre-registration degrees. Essentially, the radiation is passing through the tissue and attenuating, and it is then going to interact and damage the cancer cell DNA. It does obviously also damage our normal healthy cells as well, and that is what is then going to cause the side effects, whether that's short or long term. Radiotherapy is often referred to as the gift that keeps on giving, and that's because actually we typically find that it's an accumulative effect. So patients don't always necessarily have a single fraction of radiotherapy and then start to experience side effects straight away. For a lot of our breast and chest wall patients, we typically find that it's after the radiotherapy treatment now that they start to see some of these skin reactions. They start to see some of the side effects of treatment, one of which is fatigue, which affects probably, and it's underreported, probably about 90% of all our patients. And I can see Cassie nodding. Absolutely. I think all patients say that they feel tired, but it's proper fatigue. And that is as a consequence of the repair that's undergoing from our cells. We are finding that, you know, keeping hydrated, making sure that our patients are being physically active. So I never like to hear any healthcare professional telling patients to rest, because unfortunately now it is out of date research. There's lots of evidence, not to the point that they've got to run a marathon, but it is keeping physically active. So that may just be getting up out of their chair at least once every hour. You know, it's that kind of physical activity that we're kind of trying to promote as much as we possibly can do. One thing you'll see from this image, so this patient is lying on the couch here, and you'll see the head of the linear accelerator here. you can see here we essentially have 2 imaging devices, and that's essentially going to take a CT slice whilst we deliver the radiotherapy treatment, and that helps us make sure that our accuracy and reproducibility is as we would expect, but also just being aware of just how close the radiotherapy treatment machine gets to our patients. So it's very similar, I would imagine, to mammography, where you get real fear from patients. And I still remember the first day that I walked into a radiotherapy bunker room where you're presented with the linear accelerator, which is massive. And it does take your breath away. It's one of those things where people go, oh my gosh, it's so big, and what's going to happen to me? So there is a lot of fear around radiotherapy, and as part of being a therapeutic radiographer, we really have to support our patients as much as we possibly can do. So just quickly to talk about the radiobiology at a cellular level, obviously the main aim for us is trying to hit our cancer cells when they're undergoing mitosis, so that we can get a double DNA strand break. That is going to essentially ensure that our cancer cells are then going to go through apoptosis, and that's why radiotherapy is so effective. We need to make sure that our cells aren't hypoxic, so again, keeping physically active is important for our patients, but also thinking about the size of our tumours and some of our neoadjuvant treatments as well. So if they've had surgery or chemotherapy previously, there won't actually be a tumour there anymore. We're just using the radiotherapy for any microscopic spread that may be there, as a bit of an insurance policy, really. So just to be aware, there are other radiation treatment modalities as well. So what I've talked about is external beam radiotherapy, but there is brachytherapy as well. Traditionally, it's not really used in the UK. Radioisotope injections. There is intraoperative. So in some of the private centres in London, there is some intraoperative consultants who kind of favour that. I have to say it's very rare, and it's not something that necessarily has a better outcome. The evidence base for it isn't, as I said, there at the moment. And previously, as I talked about, proton therapy is an emerging treatment, and one will just have to wait and see to see what happens. So sometimes we can use radiotherapy palliatively. So it's a great symptom control for hemoptysis. It's great for shrinking tumours, taking pressure off of nerves. It's really effective for pain, especially bone pain. So we get lots of patients coming for palliative radiotherapy with bone pain. And as you can imagine, because of the routes of spread for breast cancer, we see quite a lot of breast cancer patients coming for radiotherapy to the bone. One thing to be aware of as well is this is obviously our linear accelerator, but we do have electron applicators. So our machine can switch between our megavoltage photons and then our more superficial electrons. So some of our patients will have what we call an electron boost, and that's to compensate for any iatrogenic spread. So if you have a scar from surgery and potentially there's iatrogenic spread there, then what we would do is then utilize the electrons, very superficial, to deliver a much higher dose at the skin surface to eradicate any of the kind of cells that potentially are left over. So sometimes patients get confused because when they're looking at radiotherapy, there's talk of electrons and photons, and again, that's a reason why RadChat exists, to try and dispel some of these and explain some of the complex terminologies that we use when we're talking about radiotherapy. So in terms of the pathway, all patients will have a CT scan. We need the CT scan data because of the Hounsfield units. So that allows us to do very detailed radiotherapy treatment planning. So all of our patients will have a CT scan, and we would essentially use that to then plan the radiotherapy treatment on. Now, the patient positioning is something that I think actually, and I've spoken to Noelle about this before, because we typically will find our patients get to radiotherapy and they really struggle with this position here. So, and it's one of the reasons why we might send a patient back into the pathway to go for more physiotherapy, which then delays their radiotherapy, which could potentially then have an impact on prognosis. So, you know, if every healthcare professional could just talk about, oh, if you ever have radiotherapy, you need to get in that position, that would help us massively. But it's not an easy position to get in, and obviously going through a CT scanner and having radiotherapy, the machines are coming very close to patients. So sometimes we do have to support them, especially if they have claustrophobia to deal with as well. But like you guys, we can put music on, and some departments use aromatherapy, holistic services to try and help and support our patients. Now, one thing that you might not be aware of is the fact that we operate within 1 to 2 millimeters of accuracy in radiotherapy. And to do that, we typically used to use permanent tattoos. So they are tiny pinprick tattoos, and essentially we would use 3, 1 in the midline and then 2 either side. And that's essentially showing to us where that patient had been in that position for their CT scan. So we could set them up on a daily basis to ensure that our radiotherapy treatment was accurate and reproducible. Thankfully, though, and my colleague Laura Charlesworth has done an amazing PhD specifically on mental health of cancer patients, and I was reading her work, and I have heard that patients have cut their tattoos out themselves with knives just because of the post-traumatic stress that they've received. So body image and everything is really something to consider. So ideally we would not want to use our radiotherapy tattoos. And that's where evolution of this technology called surface guided radiotherapy has come into play, which is revolutionizing radiotherapy, where we don't have to permanently mark our patients. They do have to be exposed, though. So from a dignity perspective, it's just something to kind of be aware of, that we do have to keep our patients with their entire top things off. We would then use a surface guided light to ensure they're in the right position on a daily basis. And the patients actually can try and move themselves. You don't even need a therapeutic radiographer to help manipulate them. So from a patient perspective, it's much better, maybe not as dignified in terms of having their top off and not being covered, but certainly in terms of not having a lasting mark on their skin. So this is just an image of the radiotherapy software, and therapeutic radiographers would typically pass through the planning side of things to plan the radiotherapy and limit the dose to our normal healthy tissues as much as possible. And you can see here the red kind of highlights where much of the dose is going. So we are here treating the supraclavicular fossa nodes. You can see this is perfect here, great radiotherapy treatment plan here, where we're obviously minimizing the dose as much as possible to the lung tissue. Radiotherapy does cause lung fibrosis. So, you know, if we were over irradiating this lung years later down the line, if they got a chest infection, they went for a plain film x-ray, they would think this looks suspicious if they weren't aware that they had had radiotherapy previously. So it does scar the lung. And one thing to be aware of is just where the heart is. So one thing that we absolutely do is cause cardiac issues if we over irradiate the heart. So we are doing what we call deep inspiration breath hold. So that's this technique here. And deep inspiration breath hold is essentially where we are coaching our patients to take a deep breath and hold their breath so that the dose is avoiding the heart as much as they possibly can do, whilst also delivering a high dose to the breast or the chest wall. And this just gives a really good example. So this would be what it was like if a patient is just free breathing. And this is with breath hold. So you can really see the difference of how we can minimize the dose to the cardiac tissue. I'm just whizzing through a little bit because I know we're slightly late. I apologize. And just to be aware of kind of things that I would love healthcare professionals to talk to patients about. One of the first things is public health. And I don't know how much you do within mammography, but I honestly, patients who smoke will double the chances of the severity of all their side effects that they're going to get through radiotherapy. Their skin reaction can be really nasty. And so as mammographers, you know, talking about public health and social prescribing can absolutely help these patients. Obviously, it's going to reduce their chances of going on to get a cancer anyway. But I promise that just supporting that patient further on in the pathway absolutely will have a benefit. Also, people are scared of radiation, and I'm sure these are conversations that you have with your patients anyway. But sometimes patients refuse radiotherapy because of their fear of radiation, and it's kind of talking and lessening some of the stereotypes associated with that. Lots of people don't necessarily keep consent forms. It's my big kind of advocacy project of keep your consent form. And I'm speaking as a cancer patient, and I have no idea where my consent form is. I was the worst kind of patient. But honestly, it's so important because patients can reflect on it. And if they get symptoms later on, there is then potential that they can kind of look at their consent form and go, well, actually, it is on there, is something that I should come to expect. And as I said, radiotherapy is the gift that keeps on giving. It isn't immediate. This is 10, 15, 20 years later when potentially these patients are getting some of these late side effects. Please visit a department. Like I would love to have mammographers coming and having a look so that they can help support their patients, and also even post-treatment reflecting on things. You know, the psychological support that you can offer or at least refer to patients could be massive when they've gone through all of this cancer diagnostic pathway, have their treatment, and then to go for those routine scans and mammograms. You know, to have someone who really understands what they've been through would be absolutely invaluable to those patients, I've no doubt. And the last thing is about, you know, you'll be having chats with these patients years later. Do they have any symptoms that could be a radiotherapy side effect? And to mention, you know, oh, have you mentioned that to your GP and said that you've had radiotherapy? And we've got some late effect social media and some podcast episodes that if you want to find out more about radiotherapy side effects, you can have a listen. And last but not least is the image library. So just something to kind of talk about. We have launched through RadChat an image library where we have patient donated images that share their radiation skin reactions, and we have 2,000 images sitting in a file waiting to be uploaded. Just got to find some time. And also immunotherapy and chemotherapy skin reactions are coming soon. So again, you know, if you want to have a look or advise your patients to go and look for resources, then it's something that you can look at. But hopefully it's going to help address some of the health inequalities that we see in radiotherapy, as a lot of the imagery is for white people. So it's making sure that imagery is there for all demographics, so patients, healthcare professionals, and also charities can access and download and use these images specifically to help address health inequalities. And you know, if you're going for radiotherapy, you don't want to see someone who's got white skin if you've got black skin. You need to be able to see, well, what's my skin going to look like, and give the right advice. And last but not least, if anyone wants to get involved, come on RadChat. Nell's done it. She was absolutely fearful, but she's done it. But if anyone wants to collaborate on anything, we would love to have you. Thank you very much.
Oh, thank you so much, Jo. What an informative presentation. Thank you so much. I think everyone will have got a lot out of that. Thank you. There's so much to talk about there. And you please, any questions, pop them in the chat or raise your hand if you have any questions for Jo. I don't know what I'm interested about the tattoo, Jo. I didn't know that there was an alternative. Yeah, that's interesting. I'll have to read up about that. And yeah, I know the image library that you're working on is just fantastic and something that I think will just grow and grow. And I know a lot of work has to go into so much work goes into everything you do, but how valuable and what a great contribution. Lindsay, you have a question?
Hi, Jo. That was amazing. As a diagnostic radiographer, it was very enlightening. There's lots for us to learn, so that was really helpful. I just wanted to ask, we're becoming less aggressive surgically with the axilla, and we're doing, rather than doing clearances, we're doing TADs and things like that. And I just wondered how that was affecting things from a radiotherapy point of view. And obviously there are lots of papers coming out to say that radiotherapy is just as effective, if not more, than sort of doing lots of invasive surgery to the axilla. Just wondered your thoughts on that.
Yeah, I think it's really interesting. And I think that's coming as a result of the impact on late effects, you know, where you start to see in lymphedema stats coming through, and people underreport things, unfortunately, in cancer. They kind of recognize that, oh, well, I've got a cure, so I can't complain about things that I'm living with. And so actually, I think a lot of the statistics we have about side effects, and specifically from surgery, aren't necessarily reported. Sometimes radiotherapy gets a bad deal because it's the treatment that comes usually at the end. They're like, oh, well, that's the radiotherapy that's caused that. I'm like, well, yeah, they have had surgery and chemotherapy as well. And so actually, it's typically an accumulative effect. But absolutely, radiotherapy is great for targeting lymph nodes, and I can envisage that oncologists, and personalized treatment dependent, they will look at kind of, you know, what is the risk for limited surgical intervention, and then increasing treatment to lymph node areas. So yeah, it will be a change of practice, but we absolutely do it now, typically with the supraclavicular fossa lymph nodes, and incorporating axilla even as an insurance. But if patients don't have to have surgical intervention, then absolutely that's a winner. Any limitation of side effect is going to be beneficial for patients.
That's great, thank you.
Yeah, thank you so much, Jo. Yeah, it's interesting to see what will happen in the next 10 years, you know, and how it will develop, and how we'll be able to be more specific. Fantastic comments in the chat here, Jo. Everybody just thinks you're bloody fantastic, and which everybody's in agreement there.
Have you paid him?
and I can just about please, the Radchat podcast, Jo and Niman were just so supportive, and such a great platform to be involved in, and I was very grateful. So definitely get in touch with Jo. And I know you mentioned about your outreach special interest group, Jo. Definitely we need some mammography representation, so we'll make sure to put that on our newsletter coming out in the next month or two, Jo. So thank you so much, and thanks for your time. Thank you. So leading on now to our next presenter is the lovely Cassie Kingswell from Breast Cancer Now. Cassie is a clinical nurse specialist for primary breast cancer with a strong focus on family history and genetics. Her role involves supporting people with gene alterations that increases their risk of breast cancer, both with or without a breast cancer diagnosis. Cassie has a wide range of experience supporting people to live well after breast cancer treatment, and the psychological needs of those before and after breast cancer. Such important work, Cassie, and thank you so much for all you do. I'm just thinking, can I share your presentation for you, or would you like to share your screen?
I've got it here now, so let me have a go at sharing. I'm far more used to being in Noelle's position hosting than presenting, so do bear with me.
Any tips? Very welcome, Cassie, please. Thank you.
You're doing a fab job, Noelle. Now, can you see the presentation there? Is that working?
We sure can. Thank you.
Perfect. All right. Tough act to follow, Jo. So there was some absolutely amazing information in that presentation, so I will do my best. As Noelle said, I'm Cassie. I'm a clinical nurse specialist with Breast Cancer Now. I work predominantly with primary breast cancer, and as Noelle said, my special area of interest is family history and genetics, but I have supported people through the whole pathway in my life as a breast care nurse. So I worked at Guy's and St Thomas's Hospital in London for about 5 to 6 years as a breast clinical nurse specialist, and before that I worked on the chemotherapy suite and oncology outpatients unit for about 5 or 6 years, so well over a decade working with all different kinds of cancer patients, and then predominantly breast cancer. So I'm here tonight to talk to you about the nursing perspective. If I could get my slide to move, bear with me 1 second. There we go. the nursing perspective of radiotherapy. So a bit about patient worries, a bit about side effects, kind of where radiotherapy fits in the whole pathway, looking at that patient as a whole, and then the support that's available for people both during and after their breast cancer treatment, which when they're coming to see you guys for their follow-up mammogram scans, so that you guys know where you can signpost people to get some more of that support. So through my work in the clinics, working with patients before they start their treatment, and also the queries and concerns that we hear through our helpline and our Ask Our Nurse service, we hear lots and lots of variety of different worries and concerns from people before they start their treatment. Any kind of new treatment can be a real mystery, and it's probably the same when they come and see you for their mammograms, either at the beginning or in their follow-up treatment. It is that fear of the unknown. I think to us as healthcare professionals, quite often you become so accustomed to the environment that you don't realise how alien it can feel to patients sometimes. And I know particularly on the chemotherapy suites, we would often kind of be going about our day-to-day, forgetting sometimes that actually this isn't day-to-day for the people coming to see us. So through the helpline, we really do hear those kind of worries and concerns that people have when they're thinking about the treatments ahead of them. So we get lots of questions and concerns around healing, skin, what impact is this going to have for me? Worries about mobility, as Jo said, in the clinics, we quite often say to people, you need to be able to get your arm over your head, but we don't necessarily, as breast care nurses and surgeons in the clinics, go into a lot of detail about what that means. So it leaves them with some questions about, well, how is my mobility actually going to be affected? Lots of questions, as I say, around side effects and particularly around body image concerns. How is this going to affect both my breast or the rest of my body image? Lots of questions around the practical side of things as well. So we actually get a lot of questions from patients about the radiation exposure. What does it mean for me? Am I going to be radioactive? Can I be around my family? These are the kind of questions that come to people when they get home quite often, and they haven't thought to ask in the clinics. And we tend to hear lots of questions around schedule. When I was a breast care nurse in the clinics, one of the main concerns for people coming to their radiotherapy treatment was around how the scheduling worked. Because radiotherapy quite often comes towards the end of primary breast cancer treatment, people might be thinking about getting back to work. They might have childcare commitments. They might be carers for older adults. And so there can be lots of worries and concerns about, well, how does this affect me and my day-to-day life? Just as they're trying to get a bit of that normality back. So as breast care nurses, part of our role is around trying to answer some of those questions for people, but also signposting them towards the clinical experts that are also going to help in the radiotherapy departments. So just to talk a little bit about side effects, both the long and short term. So we do on our website have our booklet on radiotherapy for primary breast cancer, and we go into a lot more detail than I'll be able to here around the side effects that people can see. But one of the main things, as Jo mentioned, is skin reactions, and those skin reactions can be really varied for different people. For some people, it might be quite mild, but for some people, it can be more severe, lead on to sort of blistering of the skin, and there can be some specific instruction that they need around how to manage those skin reactions. And on my next slide, I have a fantastic graphic that the Society of Radiographers have put together for patients around managing those skin reactions, what to expect and what they can do. And it's in really sort of understandable terms, so I'll share that with you in just one moment. We hear from lots of people that have some pain or discomfort after their treatment or during their treatment, and that may well be from the radiotherapy treatment itself, or it may well be related to their surgery that they would have had prior to the treatment. Lots of tightness under the arm, they can get some tightness in the breast, some swelling, and that can cause this pain. And it can be acute or it can be ongoing for some people and quite long lasting. It is quite normal, but again, it can have quite an impact on quality of life. So it's important that as nurses, we're informing people how to manage those side effects. As Jo mentioned, fatigue is an absolutely huge side effect for anybody going through breast cancer treatment, and it can be a really difficult one to manage. Fatigue, it's not just feeling tired, it's that all-encompassing kind of overwhelming extreme tiredness, we call it. And it can be one that's really difficult for people that haven't been through it to understand. And for people having radiotherapy, fatigue can actually get worse in the few weeks after they finish their treatment, which again, maybe when they're in their mind thinking, when I finish treatment, I should be looking at getting back to work, getting back to some normality. And so there can be quite a feeling of pressure. So again, as breast care nurses, we spend a lot of time talking to people about expectations and saying, you know, treatment and recovery takes as long as it takes, and it's going to be different for everybody, and there is no pressure for you to be feeling back to normal, for want of a better phrase. Fatigue can be ongoing, it can be cumulative from everything that they've been through, both the emotional impact of the diagnosis and the treatment, as well as the treatments that they've had. Again, on the Breast Cancer Now website, we've got a big web page around fatigue and how to manage it. And it is something when people are coming for their follow-up mammogram scans, they may well be mentioning to you guys, bearing in mind they may not be seeing other healthcare professionals at the time, which I'll come on to shortly. So fatigue is quite a major side effect that we do see quite often. And then back to the physical, so we can see quite a lot of swelling, and although that can be acute, it can actually be longer lasting for some people, and as nurses we'll always have the back of our mind, could this be a sign of some breast lymphedema? So we will be looking to refer back to oncologists, onto lymphedema specialists, just to rule out that there's nothing like that going on, which again can be a real concern for people. I think breast cancer patients are quite often very scared about the risk of lymphedema. So it is about sort of giving that patient education to help them know the signs and symptoms to look out for, and referring on where appropriate. This is the infographic that I mentioned. So the Society of Radiographers have put together this really good patient information sheet around skin reactions. I've got the link there, and I can send that to Noelle afterwards so that she can share it with you. But it's just really kind of understandable terms for patients to know how they can look after their skin during treatment, after treatment, and what to expect. There's even some stuff around there around sun exposure and exercise. So it's just a really nice sort of well-rounded guide for people for one of the areas that we hear most commonly from patients is a concern. You know, how do I look after my skin? What can I do to take some control over managing this? And then we speak to a lot of people, both in the clinics and on our helplines, around the longer or the later term side effects. So long term as in ongoing, late as in can be late onset. So these are things that may not have happened at the time, or they may have happened during radiotherapy and be long lasting. One example of that is pain and discomfort. So we know that for most people it will resolve in the few months after treatment, but for some people pain and discomfort can be ongoing for several months, potentially years after their breast cancer treatment. One of the ones that I feel people may well mention to you guys when they come for their follow-up mammogram scans is if they have any tenderness in the ribs or in the bones around the breast that was treated, because although we know that after radiotherapy you can get some tenderness in the ribs, people who've had treatment, their minds may well go straight to this could be secondary breast cancer, because we educate people that one of the signs and symptoms to look out for is ongoing pain in bones and joints. So that is going to be a concern for people. So if you do see people and saying, I've got ongoing pain, I'm worried about it, do refer them back to their breast care nurses and say, look, just have a chat. That's what we're there for, to talk them through those concerns, refer them back to their oncologist for more advice if needed. Quite a lot of people can experience some change in shape and size of the breast. So in particular, for example, if somebody has breast implants, they've had a reconstruction after their mastectomy using an implant, and then they've needed to have radiotherapy. The body naturally puts a capsule around the implant, and that can become tighter, and that can affect how the breast looks and feels. And for some people, again, that can be quite mild, but for others, it can be uncomfortable. It can cause body image concerns because they will have asymmetry and they may well be very conscious of that. In the more severe cases, capsules can be surgically released or removed. So again, if people are coming to see you for their follow-up scans and they say, I'm having this problem with my implant, do refer them back to their treatment teams, because we can talk them through all the ways then that they may be able to manage that. And again, even without reconstruction, if somebody has had a wide local excision, so they've just had the lump removed and the rest of the breast tissue remains, that tissue can become harder, can experience some fibrosis, some hardening. And that again can cause some body image concerns for people. It may cause some discomfort. They may be worried about lumpy areas that to them feel like it could be a new cancer, it could be a new lump, but actually might be some necrosis in the breast or just some hardened tissue. So again, I know I keep saying refer back to the teams, but the breast care nurses are there to talk through all of these concerns. So, you know, we will often be talking to people about new lumps they found in their breast. And when we investigate, we send them to you guys for ultrasounds and mammogram scans. You know, you guys will pick up fat necrosis, scar tissue, and we can put their minds at ease on that. As Jo mentioned, there can be some impact of the radiotherapy treatment to the heart and lungs, although it's very rare for that to happen these days and lots of protections are put in place. It is something that is a concern for people, so if they're worried about the impact, again, we would say have a chat with your therapeutic radiographers or your radiation oncologists, because they can put people's minds at ease on the longer term impact that that may have. And on the consent forms, they will always be consented for the risk of developing another cancer. And again, it is a very, very small risk. And we try and educate people to say the risk of the breast cancer that you've had, having a recurrence or, you know, coming back in the breast is higher than that risk of having a new cancer from the radiotherapy. So if we don't give this treatment, your risk of recurrence is higher than if we do give the treatment of you having another sort of completely separate cancer related to having had the treatment. Trying to help patients understand that can be really difficult, because they just see on the consent form, I have a risk of another cancer, and that is a worry for them. So it's about the education, about trying to talk through these risks and how it relates to them. So moving on, saying around the nursing support in all of this. So as I say, the breast care nurses, we're very much there to help educate the patient. We've quite often met them at diagnosis, have got to know them through the whole journey. In an ideal world, I know there's less breast care nurses now, and quite often we don't always get that continuity of care that we used to, but you are in a position of privilege where you get to know that patient sometimes better than some of the other treating professionals. So we're there to provide that ongoing education throughout the whole pathway. And because of that relationship, that rapport you build with the patient, you are really in place as their key worker, as their advocate. So when it comes to the MDT communication, as Jo mentioned, there is such a wide MDT team when it comes to treating breast cancer. And the breast care nurse has a really lovely position within that to be able to express the wishes of that patient, to really represent them in that process. And it's such an important part of the role that I always really try and impress on people that we really are the advocate for that patient sitting in that MDT team. We will know if they have mobility problems, we will know what their fears and concerns are, what their wishes might be. And so it's making sure that you speak up and express that in the MDT communication. Also there for the practical and emotional support. So from a practical side, talking to people about how the treatments work, making sure their questions are answered, but also the emotional side is absolutely so essential. It's such an emotional time going through a breast cancer diagnosis and treatment, and all of these treatments are a real unknown for the patients, and it can have a huge emotional impact. We know that depression scores are higher in people post-treatment for breast cancer. We know that anxiety can also be a difficult problem. We know that in our older patients, depression and anxiety quite often go unrecognised. We know that older patients can be quite isolated after treatment, and that doesn't always get picked up. So we utilise things like the health needs assessments as nurses to try and pick up on those social and psychological factors, and then either provide the support or signpost people on to the support that's available. So we have so many amazing healthcare professionals that we can refer on to, be that physiotherapists, psychologists, counsellors. There's so much support out there, and it's just having those conversations with patients that you can help them know what support is there and help them to utilise it. And that really is kind of the crux of a breast care nurse role, is bringing all of that together. And when I say I like to think about it in terms of the bigger picture. So as Jo alluded to, radiotherapy isn't a treatment in isolation. There are so many different treatments for breast cancer that all have an impact on that person, and you can't pick them apart. You have to see that person as a whole. And I really love this graphic here from the Penny Bron Institute. that looks at the impact on the patient in the middle and all the different elements around the outside that have an impact on that individual. So we're looking at the emotional impact of the treatment, but actually how the physical interplays with that, the impact on their relationships, on their home situation. We have to picture all of that together to actually be able to support that person. When it comes to the treatments, obviously somebody may well have had chemotherapy, and those side effects will still be ongoing when they come to have their radiotherapy treatment. They will also potentially, if they have an ER-positive breast cancer, be starting on hormone therapies, so either letrozole and anastrozole tamoxifen. And we tend to be starting those in clinics either alongside the radiotherapy or in a lot of cases just after they finish, depending on where that person's being treated. So those impacts, those side effects can well be hitting at the same time. You also might find that you have patients with an ER-positive cancer who have been brought off of their HRT if they were on HRT before treatment. Sorry, that I can hear somebody else speaking, it's put me off, sorry. So if somebody's been on HRT before they start their treatment, they may well have been asked to stop it. And if you think surgery tends to take place if they haven't had chemotherapy 8, maybe 10 weeks before radiotherapy, they may well be starting to feel the impact of coming off that HRT, have menopause symptoms starting to set back in, or if they've started hormone therapies, might be starting to develop menopausal symptoms. And that can have a real impact on quality of life for people. So when we're seeing them in the clinics, we're actually thinking, what are all these other things that are going on for that patient? All of this can have a huge impact again on the emotions and the body image for that patient. And the body image changes particularly around with menopausal symptoms, if it's having an effect on their libido, on their sex life, on how they feel about themselves. Same as with surgery, you know, having a mastectomy, having a lumpectomy may well have a huge impact on how somebody feels about themselves. People can sometimes be worried about talking about these side effects. So it's about being open and saying, actually, it's okay to talk about this. I'm going to broach this subject to make you feel comfortable so that you know that you can talk about it. And again, from a nursing perspective, we know quite often that is our role. And the other thing to think about is the diet and lifestyle advice. So we know that to reduce the risk of recurrence, being physically active, keeping a healthy body weight and reducing alcohol can all have a huge impact. And I did a webinar with a lovely lady called Caroline Tweedy, who some of you may well know, who is a fantastic practitioner, and she talked about teachable moments. And I think as breast care nurses, when people are coming towards the end of their treatment with radiotherapy, that's a real teachable moment where we can start talking about life beyond cancer and how can I take a bit of control back. And giving some diet and lifestyle advice can be really, really beneficial in that situation. Then I wanted to very briefly just talk about the support available for people as they're going through treatment and beyond. So obviously breast care nurses are always at the end of the phone. We are the key worker for that patient, and we can very often signpost to the other support. So people quite often may well be coming into their follow-up scans and saying to you, I don't want to bother my team, I don't have contact with my breast care nurse anymore. And I would always say, advocate, say no, just give them a call. You have the contact number for your breast care nurse, call them. Because if people are on open access follow-up, when they finish their radiotherapy, they may not see another clinical person until they come for their mammogram scan. So all those kind of fears around what could be found on the mammogram, having that first scan, that anxiety, any side effects they might have been experiencing and haven't talked about, it's quite possibly going to be you guys that they're going to come and talk to. So please do, you know, feel that you can signpost them back to their teams. So chat to your breast care nurses. From there, we can, you know, get advice from their radiographers, from their oncologists, from their surgeons. GPs and primary care teams are also a fantastic source of support for a lot of people. And then there is a huge online community for breast cancer patients, and so many different resources people can access for that peer support to feel less isolated. So we do signpost people to use the online community. And then of course there are charities like Breast Cancer Now. So I can't give a presentation without doing a bit of a plug for our services. So, as I've said before, radiotherapy is quite often the last treatment in primary breast cancer before people are then into that follow-up process. And it can be a time that is really quite emotionally challenging. There's a lot of pressure felt by people at this stage, and that is acknowledged in the research. And so we created the programme called Moving Forward, and that is to support people as they're making that transition from treatment into follow-up back to trying to find what is normal for them now. So Moving Forward is run in small groups. They get that peer support with other people going through the same situation, and they get lots of presentations around managing side effects, diet, exercise. They get a Q&A with a breast care nurse to ask all those little niggling questions that they haven't felt able to ask their teams. So that's a fantastic resource that you can sign people onto if they're coming for their scans and they say, I'm struggling, I'm not sure where to turn to for support. It's a really great programme to signpost people to. We also have some specialist services that you can signpost people to. So we have our younger women's services, our secondary breast cancer services, and we also have our Someone Like Me service, which is a buddy service where people can be linked with a trained volunteer who's been through breast cancer, and they can ask to be matched with somebody in a similar situation. So you may have somebody who says, I've had quite extreme skin reactions after my radiotherapy. I'd like to speak to somebody else who's been through it to see if there's any tips that help them. You might have somebody who says, I'm a young mum and I'm trying to manage childcare alongside having my treatment, and they can buddy them up with somebody who's been through similar. So it's a fantastic service to use. But of course, Breast Cancer Now aren't the only charity supporting people. There are loads of other charities out there. So I've put just a few examples on here, but that really is a drop in the ocean. Macmillan have some fantastic information and support. You've got Cancer Focus over there in Northern Ireland. And then the few other examples I've put here, I've tailored around sort of exercise advice. So 5K Your Way that Joe mentioned, Get Me Back have a fantastic breast cancer programme. And then there's charities like We Are Undefeatable, who support people with all different kinds of long-term health conditions to be active, to take some control back over bringing back their activity. So there are just so many resources out there to signpost people to. It's impossible to know all of them. So if people are coming to you for their mammogram scans and they've got questions and concerns and you think, I'm sure there's support out there for them, please do get them to give our helpline a call, because we can direct them on to the different support services that they can access. Just to very quickly finish with the support we have available for healthcare professionals. So through our healthcare professional hub that you can see an image of there, you can access all of our webinars, which cover lots of different areas of breast cancer. We have some around screening, around different treatments, around family history and genetics, and also around sort of follow-up. We've done a radiotherapy series with the guys from RadChat, which I've put an image of there, and cover a little bit of anything and everything. So through the Healthcare Professional Hub, you can access those webinars, get CPD points, and we try and cover absolutely everything. We also have our HCP specialist group. So I have one for family history and genetics. There's one for secondary breast cancer and one for younger women. But the one that will hopefully be most interesting for you guys is we do have the new screenings champion group. They had their meeting today and will be aiming to meet every sort of 3 months. So if you are interested in another avenue of getting that peer support with other healthcare professionals working in breast screening, it's another avenue that you can use, like your webinar tonight, just to get some more support with your peers. That was an absolute whistle-stop tour through. As I say, please do feel free to signpost the people that you're meeting in clinics onto our helpline, because we can direct people onto all those different support services that they can access. But really, kind of as a breast care nurse, I really do advocate for that individualized, personalized approach of seeing each person as an individual, seeing the whole in the process, and just remembering that when they're coming to you for their annual scans, they may not be seeing other healthcare professionals because of open access follow-up, and there's very limited person-to-person connection. So please do just encourage them to call their breast care nurses if they have concerns, because they will always be there at the end of the phone to talk to. And that is it for me. Thank you.
Thank you so much, Cassie. That's fantastic. And you mentioned about teachable moments. I think, screening appointments are so brief, but there are those little nuggets that where we can really make an impact and direct and signpost. And when we've been informed with such available information, that is out there, Cassie, just that we need to tap into. That's been really, really helpful. Thank you. Emily, you have your hand up there.
I do, yeah. Just a quick question. Thank you so much, Cassie. That was really, really interesting. So it's just in relation, you mentioned that patients often have questions and concerns about scheduling of radiotherapy. So it was just about DNAs. It might be a really silly question, but if a patient does DNA, say for 1 or 2 days within their radiotherapy treatment, what happens then? Are those days sort of added on to the end, or is the treatment sort of stopped and fully rescheduled? How does it work?
Back where I was working in Guy's and St Thomas's, it would be added on to the end, but there would be lots of contact made from the radiotherapy team after one DNA to see what was happening with that patient. Is there a reason? I remember there being patients where it was problems with transport, or they might be having problems at home. Is there something we can solve for that patient to avoid those gaps? Because we know that it's better not to have gaps in treatment. I don't know if Jo has any more insight on that being still in clinical practice, but I know back when I was at Guy's and St Thomas's, we wouldn't restart the treatment. It would just be added on to the end, but we would do our best to avoid as many delays as possible.
We can do something called hypofractionation, where you actually have 2 radiotherapy sessions in a day with at least 6 hours apart, just to allow for normal cells to be able to repair themselves. But typically it is added on to the end. But what you don't want is big gaps in between a curative intent.
And of course, since the fast forward trial, now that we're giving radiotherapy more commonly over 5 days rather than 3 weeks, I would imagine that sort of DNA rates are probably less problematic.
Yeah. Oh, that's great. Thank you. Thank you both.
Yeah, thank you. Thanks for your question, Emily. And Lindsay, you should fire ahead.
Hi, it was more just actually just to thank you again for another excellent presentation, and just really to comment on how helpful, as working in a symptomatic department, we are undertaking imaging-led follow-up. And it's not traditionally, where in years gone by, we weren't the first person that patient would see coming for their mammogram every year. And I think it was really helpful when you showed that patient information sheet, and also for us as professionals about the side effects. And we do, particularly in the ultrasound department, see a lot of patients coming back, and the surgeons and the nurses do field a lot of it, but we still get anxious patients with red breasts and hard lumps that weren't there a year ago. And we do try and explain that this can develop over a prolonged period of time, but it's just useful, I think, to highlight that for us, that that there is this guidance out there for us.
Absolutely. And if you're not sure where to signpost people, you can always get them to call Breast Cancer Now, where we'll let them know which health professional, although it does tend to be their breast care nurses, that we would say to get in contact with, because as you say, with open access follow-up, they're not getting that regular contact. And we do speak to a lot of people that call us and say, but I'm going for my mammogram next week, so I've not spoken to anybody. So yeah, I think they are seeing sort of mammogram scans quite often as their follow-up appointments, are bringing more questions and concerns your way.
Yeah, thank you.
Definitely that society crib sheet, Cassie, is excellent. That'll be so helpful for trainee mammographers and people that myself, someone that should know these things, but just to act as a reminder for healthcare professionals as well as patients and clients. So thank you so much, Cassie. So informative and helpful, and it's great collaboration alongside nursing and radiographers too. So thank you so much for that, Cassie. We'll move on if that's okay. to our next fantastic speaker, Susie McConnell. So Susie's an advanced practitioner from Kettering. Susie has worked as a radiographer in the NHS for 19 years with a background in radiotherapy originally. She was working as an advanced practitioner in the pre-treatment area, completing a PGC and specialising in breast and palliative planning. 3 years ago, she took the leap and she decided to make the move into mammography to continue her interest in breast cancer care. She has now taken on the role as trainee advanced practitioner and has returned to her studies, currently undertaking the breast interventional module with the University of Salford. Susie, I bet they're very lucky to have you working in Kettering. We're really looking forward to your presentation.
Oh, thank you very much. Can you see and hear me okay? Hi, is my mic working?
Yes.
Lovely,
Yeah,
Susie, already. Lovely.
Yeah, can you see the presentation? Sorry, I'm just having some technical troubles. I'm trying to get my presentation.
Take your time. You're fine, Susie. Sometimes it just takes a minute to get going. Ivy, you have your hand up. Are you okay? Or is that a little hello?
No, it's just a thumbs up to say I can see everything well.
But that's what we want, Ivy. That's great. Lovely. It's a lovely. Don't worry, Susie, take your time. Lovely. And I think I'm really excited to hear, it has been a really common pathway now with radiographers coming from that therapeutic background and definitely enriching our workforce. So it's fantastic. It'll be really interesting, Susie, to hear you speak today. Jo,
I was just going to say, I think 10 of our students this year are wanting to go into mammography. So, yeah.
That's incredible. That's incredible, isn't it? 10. And that's 1 year, Jo. Oh my goodness. It's there's definitely yes.
Oh, you can hear me now. That's fine.
Lovely. And can you move your slide, Susie? Are you okay to move on from? I'm just going to check. Oh, perfect. Yeah, lovely. You go for it. Lovely.
Okay, lovely. Right. Thank you. Yes, so thanks very much. It will overlap, I think, slightly with Jo's, especially because I didn't really know what she was going to cover. So bear with me if I'm repeating things that you've already heard this evening. But just a bit of background about me. So I qualified as a therapeutic radiographer in 2006 from the University of Hertfordshire. And I started working at Northampton General Hospital, which was the local hospital to me. With radiotherapy, as you know, there's not that many centres really spread throughout the country. So a lot of people have to travel, patients, they have to travel quite a long way sometimes, but also the staff as well. We don't necessarily work really, really local to where we live. So I was living 30 miles away from where I worked, which doesn't sound like a lot, but it was a single carriageway road. It wasn't the easiest road. If there was any roadworks, traffic, anything like that, you were stuck. But I'd always wanted to do radiotherapy. It was the only thing I ever wanted to do. So I travelled, I did it every day. In 2008, I was promoted to band 6. So at this point, I was a rotational radiographer. So as Jo has already mentioned, there are certain different areas of the radiotherapy department. So you have your planning stage, which is where they come and have the CT scan done. It then goes to physics, where they have the plan made up. It goes to the calc and prep area, where you work out your doses, you map the treatment sheets, you get everything prepared and ready to go, and then the treatment machines. So you rotate around all of those areas. So when you take on the band 6 role, you obviously take on more responsibility. It becomes a little bit more managerial. You're responsible for managing your team, for managing your day, making sure your patient appointments are all convenient, everything's working. The machines have to be serviced regularly, obviously, so you have to make sure that you're allowing for that, that you've got the correct skills mix to cover things like that. So alongside your clinical skills becoming more broad, you're also taking on a bit of a managerial role as well. So by kind of 2010, I was a team leader on a busy linear accelerator, treating maybe 40 patients a day. I then decided to go off and have a family. So when I came back at the beginning of 2014, I nearly didn't come back, actually, just because of, as I say, the logistics of where I lived compared to where I worked. It was really difficult to find childcare and the cost of childcare. So I came back just one day a week, and that was really just so that I could keep my hand in, I could keep my skills up. The manager at the time was concerned that I wouldn't be able to keep my competencies up. I wouldn't be able to be a team leader, rotate around all of the departments and keep my mandatory training up to date. And she actually wanted me to down band back to a band 5, which I wasn't keen on doing. So we came to an agreement that I would choose one area of the department that I would work in, and we would see how it goes. She gave me a 6-month grace period to prove that I was able to do it. So I chose the pre-treatment area because that had always been my favourite. So the first stage where the patient comes into you, the stage where you do the planning, where you do the CT scan. So that was the area I chose, and I worked there quite happily. My one day a week, I used to swan in and swan out, as my colleagues used to say. And I did that for the best part of nearly 2 years. And then at the end of 2015, the superintendent radiographer in the pre-treatment area was retiring. So 2 of my colleagues took on her role between them, and they worked half a week each. So I then took on an advanced practitioner role, and I bridged the gap between them. So I worked 3 days in the middle of the week to keep that continuity going. And because it was an advanced practitioner role, it requires me to undertake extra studies. So I got my postgrad certificate through Sheffield Hallam University in 2018. And 2 of the modules that I did as part of that were, one was allow me to mark up breast planning treatments. So that was a task that had originally been a consultant oncologist's role, but the radiographers were able to undertake extra training to be able to do that, which had then freed the consultants up to do more complex stuff and stuff that the radiographers couldn't do. So I did that. I was one of 3 radiographers that did that at the time. And then I went on and I did a palliative planning module, which allowed me to plan palliative bone radiotherapy and whole brain treatments. So I did that for a couple of years. And then it was the start of 2020, and I kind of thought, right, where am I going to go from here? What do I want to do? I was itching to kind of progress a little bit more, but I didn't really know what to do. And a consultant radiographer palliative planning post came up, and I was really interested, but it was made very clear to me that it was a full-time position. It was 5 days a week, and those 5 days were clinical on site, and there was no flexibility around that. That's what it was. Unfortunately, it just wasn't feasible for me with my family life, and also as I say, with that the traveling had got worse and worse and worse. As we know, population has increased, there was more houses being built, there was more traffic on the roads. I had about a 3-hour journey, 1.5 hours there and back every day. Doing that 3 days a week was really tiring, and the idea of doing it 5 days a week, I was just like, I can't do this. So I stayed put in my 3 days a week. I just, enjoyed what I was doing. A couple of months later, COVID hit, and there's a picture of me the first day that we had to get all PPE'd up. So that was fun. I'm sure we all remember that. But in radiotherapy, we didn't stop. Nothing stopped. The service didn't ease up. It didn't stop. We carried on doing what we were doing. We just had to implement extra cleaning. Our days were ever so slightly longer, if anything, but the patients kept coming, and we kept a sense of normality, which was actually quite a good thing for us. We were quite lucky, really, because a lot of people had to really adapt and really change things, but we just kept going through. So moving on to the end of 2021, and I was approaching the big 40. We were still in COVID, it was still a thing, and I was tired, I was stressed, I was still dealing with this traveling, and I thought to myself, I've got 25 to 28 more years of this to go. What am I going to do? I can't do this for very much longer. And I really, really didn't know what I was going to do. I was considering leaving the NHS, but I didn't know how, I didn't know what I was going to be doing with myself. I needed something that I could transfer my skills to. And then a mammography job came up, and it was because Sophie, I was working with Sophie at the time. She was moving back to Belfast. She'd taken on a job in mammography, in breast screening. And when she told me, I thought, oh, I wonder if this is something that I could look at. So I went home and I logged on to NHS jobs, and lo and behold, there was a job in Kettering, which is my local hospital. It's less than 10 miles away from where I live. It's a 16-minute door-to-door journey. And I thought, what's the worst that can happen? So I fired off an application form and I sent it in. At that point, I didn't know what mammography entailed. I didn't even know what a mammography department looked like. I'd never stepped foot in one. But I thought, what's the worst that can happen? Let's see where this can go. So I applied. So I'll talk a little bit more about that later on, but I just want to go back to what I was doing at the time. So as I say, I was working in the pre-treatment area. Joe's already talked a lot about radiotherapy, about pre-treatment, so I'm not gonna go over it too much more. But basically, it's generally the first step in the radiotherapy process. Often it's the first time a patient has walked into a radiotherapy department. So as Cassie and Joe have both mentioned, the anxiety that the patient might be feeling, the fear of the unknown, the worry. So we, as well as being radiographers that are there to plan their treatment, we also work as a comfort to them as well, to try and put them at ease, to try and answer their questions, and to try and make the whole process as easy as possible for them. So within planning and within the pre-treatment area, there's different aspects depending on what sort of treatment they're having done. So this one here, as you can see from the picture, this is somebody who's having treatment to the head and neck area. So because it is so finely targeted and we don't want any movement and we don't want any damage to any of the other surrounding organs, we make these immobilization devices. So this mask here will clip down onto the bed. It's made especially for that patient. It's only used the once, and then the patient either takes it home or it gets destroyed. It's not reused. And it means that we can ensure accuracy every single day. We can ensure the patient is not moving, and also we can put all of the marks that we need onto that mask, so we're not having to put any markings on their skin, on their face. So when I was doing the pre-treatment job, that was part of my role. I was the mold room lead. So I was responsible for leading the team that would make these sorts of things, and also bringing in any new techniques and any new developments. Some radiographers choose to go down the consent route. So again, it's helping the shortage of clinical oncologists by expanding the radiographer's practice, which is great for them. It's great for career progression. It's great for job satisfaction, and it also helps with that shortfall of the consultant oncologists. It frees them up to do the jobs that they need to be doing that none of us can do. So a lot of radiographers will go down the consenting route. So they will see the patients when they first come in. They will go through the whole process of radiotherapy, the risks, the benefits, the side effects, give them informed consent and make sure they're happy to go ahead with it. And that can include other things like bladder and bowel prep. If they're having like lower GI radiotherapy, they might need specific bladder and bowel prep. And they can go through all of that with them at the consent process. So that's something else that gets done during planning. And then, as Joe mentioned, that everybody has a CT scan. Many of the scans will require IV contrast as well for greater detail. So it will be the pre-treatment team's job to cannulate the patients. So they need to be confident and competent with that. They also need to be able to confidently work the IV pump injector and then also look out for any side effects. So they have to be anaphylaxis trained and be aware of things like extravasation and what to do in that kind of thing. So there's actually a lot that goes on in the pre-treatment area other than just a CT scan. So once they've had the scan, as has already been previously mentioned, tattoos, which are permanent markings, or surface guided radiotherapy, which is becoming more and more commonplace, and then the planning process. And again, Joe's already gone through this in greater detail, but just basically to mention that there are a couple of different ways of doing the radiotherapy planning. So you can go through physics planning, which tends to be the more complex plans, that requires the contouring and the outlining of the pictures that Joe shared with us, looking at organs at risk, making sure that doses aren't exceeded, making sure that the healthy tissue is kept as healthy as possible. It's a very time-consuming process. It involves a team, usually radiographers, dosimetrists, physics experts, and the consultants, and everything that's done has to be double-checked. So this process itself can sometimes take up to around about 2 weeks from the start to the finish. So if you think of a patient who's just keen to get started with their radiotherapy, giving them a realistic time frame at planning to explain why they have often a 2-week wait before they start treatment is really important. But on the flip side of it, you have the virtual sim planning as well, which is normally done for palliative. It's the less complex, it's the more simple, if you like, treatment plans. It's a lot quicker, and it's often done by the radiographers with relevant qualifications. So I was able to do breast, bone, and the palliative brain, and a couple of my colleagues also did lung and soft tissue. So just to put it into perspective, a virtual sim plan can often be done, planned and checked, and out of the department within an hour, compared to your 2 weeks for your physics plans. So very, very different. So I've already said radiotherapy was the only thing that I'd ever wanted to do. I loved my job. I loved the busyness of it. I loved the variety of it. So why did I eventually make the swap? So the big birthday came, and it was maybe midlife crisis come early, but it was a case of what do you want to do with yourself for the next 25 years? If, you know, career progression was really, really important to me, but it had been made very clear that there was no flexibility. It was full time, it was 5 days a week, and it was only based in the department. There was no chance of working from home. I had to be really realistic. I had to make a decision. COVID as well on top of it, as I said, we didn't stop. Nothing stopped. It became really, really difficult for me. Funnily enough, at the time when I applied for the mammography job, and I didn't tell anyone, I didn't even tell my husband, and I came and I had a tour of the department, and I absolutely loved it. I loved the feel of the department. I loved the team. I loved it. Just had a real family feel to it, and it just made me feel really, really comfortable. But the day that I actually went for the tour of the department, I was working from home because my husband and my son both had tested positive for COVID. And at that point, they had to isolate for 14 days, I think it was. So they were both isolating in their bedrooms. And I had arranged to work from home because my daughter and I were both still testing negative every day. But my childminder wouldn't take my daughter because she didn't want to run the risk of taking COVID, getting COVID passed to her and taking it into her family home. So I had nobody to drop my daughter off at school and pick her back up again. It was a really, really stressful time. And when I spoke to work, they were really unsympathetic towards it. In fact, when I came off the phone the first time, I broke down. I was in tears because I was at breaking point, and I just didn't know what to do. There was no help, there was no flexibility, there was no sympathy. And at that point I thought, well, you know, is this not just meant to be? So I went for the tour of the department, I went for the interview, and at that point I said to my husband, so I'm thinking of maybe making a little bit of a career switch. And bless him, he was very good. He was very very supportive of me. So it was 4 months later when I finally left radiotherapy and went into mammography, and honestly I felt the weight lifting off my shoulders as soon as I did it. I had intended to go and do some bank shifts in radiotherapy to keep my competencies up. I was hoping to kind of do a little bit of both, and I did go back. I went back 3 times over a 6-month period, but I realised quite quickly how difficult it is to keep your competencies up. It wasn't going to be easy, but also I didn't realise how close to burnout I actually was until I stepped away and looked at it. So I made the decision at that point not to go back. So I've not stepped foot in a radiotherapy department for 2.5 years now, I think. So some of the benefits and challenges of making the switch. So as you can see, the benefits outweigh the challenges for me personally. And I think a lot of it, as you know, I've said it repeatedly, the distance closer to home, that has made such a difference to me. I get so much more family time. I'm happier, I'm less tired, I'm less stressed, my family are happier. It brought new goals. I always like new goals. I always like to be challenged. I always like to progress. I get bored quite easily, and I don't really like to be stuck. I find that mammography is a slower pace than radiotherapy. It's less demanding and it's less stressful. It still has its demands and it still has its stresses, as any job in the NHS does. It still has its politics. It all does. But for me personally, I just find it a lot easier. And I had a lot of transferable skills, which I think have been really beneficial. And it goes back to what's been spoken about a lot tonight. I feel like I'm quite well placed to give patient advice, especially when they've finished all of their treatment and they then start coming back for their surveillance mammograms. And I instantly see the tattoos and say, oh, you've had radiotherapy, that's my background. And then they open up to me and they might ask me advice, and they might say, you know, this breast feels different, and I can give them all the advice on that. I always signpost them to their breast care nurses, but I also, because I'm so well placed, I also now have the capability of going and speaking to the breast care nurses or the surgeons myself. So it's really nice. I think what I was worried about when I came into mammography, when I came into breast screening, was I thought it was going to be very much a conveyor belt. You would see a lady once, you would do a mammogram, and off she would go. I didn't appreciate quite how much there is to it and quite how involved you can get, and that you can make a bit of a relationship with the patients. And I think having the radiotherapy background and being able to bring that into them, I think has been really nice, and I think it's good for the patients as well. I think it's been nice for them. It has had its challenges. I'm studying again, so obviously when I made the switch to mammography, I had to undertake the BIP breast screening module. I had to learn a completely new skill, and it is very different, and mammographers make it look really easy, and it's not. And I was like, when I first started, I felt like I needed to be an octopus. I needed like an extra set of hands. I had just absolutely no idea how the mammographers did it and made it look so effortless. But I managed to get my head around it, and I've got used to it. And getting used to a new department, I'd only ever worked in one department, and I'd worked there for nearly 20 years. I'd studied, trained there, and worked there and built my way up there. I'd got quite comfortable. So moving to a new department was really, really daunting, but they are so lovely, and it is a really small department and a small team, and I think that helped me with my transition. So what do I enjoy about my role? I enjoy the variety. It is a lot more varied than you realise. It's a symptomatic and screening department that I work in, so I get to see a bit of both. I get to do a bit of both, which keeps it interesting. I'm, now that I've taken on the trainee advanced practitioner post, I'm getting to be involved in MDTs, so I'm really enjoying that. It is something that I used to do in my previous role anyway, so being able to get back involved in it is nice, although from a completely different side and different aspect. It's the small team. It's got a real family feel to it. A lot of the ladies have been there for many, many years and know each other really well. But they're really welcoming, and it's been really lovely to go in. I've enjoyed it. They work really, really well as a team. There's no them and us. And sometimes in radiography, in radiotherapy, it can feel like them and us, because you have the different parts of the radiotherapy department. So you can feel like pre-treatment is one team and treatment is another team. You don't have that in breast screening. You're all working together. Even the breast clinics and the breast care nurses, you know, you're all working together collaboratively for the patients, and it's really lovely. And the management in my department are lovely. They have a really nice open door policy. They're very supportive. They're very flexible, they're very adaptable, and they really do everything to help you. They all have their own families, so they're really helpful when, you know, when I am having issues with my children, or if I need to leave early for parents' evening. They're really willing to help you with that, which I've never had before, because unfortunately radiotherapy, it doesn't have flexibility. It can't have flexibility because it has to run the way it runs. And the other thing that I like about mammography is the possibility of progression, which I didn't think I was going to get. So I've already started my advanced practice pathway again. I was very honest when I came for the interview, and I said to the manager there, I said, I will want to progress, and I will want to progress quickly, because that's just how I am. And she said to me, you know, if it's available, absolutely, we'll look at that. And I've been really lucky. And I think that's due to the ageing workforce and the fact that many of the mammographers are retiring, and these job prospects are being opened up to us. So what is next for me? So I've just taken on the trainee advanced practitioner role. I started that in June last year, so it's coming up to a year. Funnily enough, I have now gone back full time after saying that I wasn't sure I wanted to do it. But I do 4 long days there, so I still get a day to myself. I do 4 long days, and because of the less travel time, I'm still home more than I was when I was working in my previous role. I'm currently training to do stereotactic biopsies, so I'm training through the University of Salford at the moment. I've actually had an online training session all day with them, so I'm a little bit PowerPointed out today, but I'm enjoying that. That's going well. And in terms of future aspirations, I haven't actually made my mind up yet. I would really, really like to do film reading in the future if that's an option. But as far as the long-term goals, consultant radiographer has always been something that I've been interested in. But I also enjoy the management side of things. And in my previous post, I was lucky that I was able to do a little bit of both. So I'm keeping my options open, but for this moment in time, I'm just really excited with how things are going, and I'm really enjoying what I'm doing. So thank you for listening. I feel like I've literally just talked very quickly about myself for 20 odd minutes, which is very unlike me, but I hope it's been interesting. I hope it's given some people a bit of an insight, and thank you very much.
Thank you so much, Susie. Yeah, great insight there into the many spokes that come into, you know, taking on different roles and developing. And I suppose with every job you have as a enhanced and advanced practitioner, you take on learning from each opportunity, and it builds you into the practitioner you are. So it's fantastic, Susie, and we wish you all the best with your studies, and yeah, please keep in touch with the BISIG. It's fantastic to have you on board. Yeah, I know we are definitely over time here this evening, and I've definitely misjudged things, you know, so apologies, do blame me for that. We do have one more speaker Please put any questions you may have for Susie in the chat, and we'll introduce our final, but by no means least, our lovely colleague from Belfast, Aideen McFall. Aideen is an experienced general and cardiac radiographer who specialised in breast imaging in 21. Aideen is a member of the Belfast Trust Patient Informed Choice team and is active in breast awareness endeavours across the Belfast community. What makes Aideen so interesting is she also is a makeup artist with over 20 years of experience. And as a Paddy McGurgan Academy alumni, she extends her skill set to include semi-permanent makeup. That's why my eyebrows are so on fleek, by the way, ladies, just to let you know. Anyway, with the support of the Belfast Trust, imaging and the surgical teams, Aideen has been able, as a mammographer, to utilise her skills as a medical tattooist. And I think this is so relevant today. You know, we've spoken a little bit today about body image and the importance of post-treatment endeavours for our patients and undergoing treatment, and the work Aideen does is just so valuable and interesting to come from a radiography background. So I'll let Aideen take it away there.
Hi everybody. Technical issues. Is that okay?
That's it.
So I'll just check if everybody can hear. If you just give a wee thumbs up if you can hear me. Or not.
We can hear you.
Yeah, that's good. So I'm going to share my screen in a minute. Just going to, first of all, thank Noelle and the team for all the preparation and organisation that has gone into the webinar. And I really appreciate everybody being here and sticking on for me to speak this afternoon or this evening. And thank you to everybody that went ahead of me. So I'll not be too long. I'll give you hopefully a bit of an insight into my involvement in post-mastectomy medical tattooing, and a quick overview of my journey as a radiographer and how my other hobbies and interests have coincided with my job to lead me to where I am today. So we'll get that up for you now. Okay, so just an introduction to me. I graduated in diagnostic radiography in 2009 and began working for the Northern Trust in the Mid-Ulster Hospital. And a year later, I was offered a permanent post in Antrim Area Hospital, where I worked for as a Band 5 radiographer before progressing to a Band 6 general radiography post. So after 6 years and a brief encounter with cardiac imaging, I got a taste for expanding my skill set and accepted a job in the cardiac catheterization labs in the Royal Victoria Hospital in Belfast. So having admired the multidisciplinary environment and witnessing at firsthand the integral role of a radiographer in the treatment of cardiac disease, I became invested in pursuing a career with the more patient interaction and involvement. And in 2022, I transitioned to breast imaging, completing my postgrad certification in mammography and continuing on to become part of the Promoting Informed Choice team. And like Noelle said, there with a background in makeup and semi-permanent makeup, I began to explore opportunities to incorporate my love of creativity and my desire to have a positive impact on a patient's journey through cancer treatment. After numerous emails and persistence, I managed to persuade the breast surgical team that I would be a beneficial asset to their department, and that would lead me to undergo the areolar pigmentation and MCA training course in May of 2024. So after 20 years in the makeup industry and 15 in diagnostic radiography, I managed to extend my scope of practice, enabling the transfer of skills between both professions for the benefit of the patients using the breast service. Next slide. So working in a multidisciplinary team enables collaborative working between mammographers, breast surgeons, breast care workers, or nurses, and radiologists, offering the possibility to share professional expertise and experiences. Liaising with the multidisciplinary team can determine the most appropriate diagnostic procedure to suit the patient
and provides an opportunity to act as the patient's advocate. And it's through this interprofessional relationship that we complement each other's expertise and value the opinions of all professionals. So such relationships have opened the door to many opportunities for career progression and improved skills mix, allowing mammographers to become more involved with patients. As a mammographer, I work frequently in symptomatic setting, meeting patients who are at the beginning of their breast cancer journey and those who are undergoing self-directed aftercare. And what I've come to realise is that treatment doesn't just stop at a surgical level, but that the mental and physical debilitation can be as difficult to endure as the treatment itself. Patients often articulate their inability to accept their bodies after surgery, a lot of whom have lost nipples and feel disfigured or incomplete. And the significance of body esteem and mental health have been researched to show a direct linear correlation with mood, anxiety, and quality of life being negatively affected as a result. So this emphasises the importance of improving the aesthetics of surgical treatment and subsequently optimising the treatment outcome for the patient. So what is medical tattooing? Just move on here.
Yeah, it's just slow.
Oh, okay.
Yeah.
So areolar pigmentation is the implantation of semi-permanent pigment into the skin using an electronic device with a cluster of needles. The shape, size, colour of the areola and nipple created can be determined by the patient's personal preference using the existing nipple for comparison where applicable, or in the case of a double mastectomy, tailoring the outcome to the specification of the patient. I just want to check, are you all seeing these slides move on, or I think it seems to be frozen here?
I'm not seeing the slides moving.
Yeah.
Just
Still on the background.
Can I try and share here? Yeah, go ahead.
So I'll keep talking here just while we're working this out. So the procedure starts with mapping the area, and it can be individually enhanced to include Montgomery glands and creases, and it provides a more realistic appearance. So I've personally been certified in 3D areolar pigmentation, and although the NHS do provide a 2D service, I have the ability to utilise these skills and create a more 3D version of that.
Yeah, I can see it.
So I think that's it now, you can see. So the top picture here on the right, it shows my very first model. He had a rare malignant melanoma in both breasts and underwent bilateral excisions. So she unfortunately went on to develop infections in both surgical sites, which left her with extensive scarring and discoloration. The skin was really thick and difficult to penetrate. However, the procedure ended up a success, and the immediate emotional impact was overwhelming, and this transcended throughout the room. It was a really heartwarming moment for both of us and very memorable experience for myself. And the other treatment just below there that I can offer is a multi-trypanic collagen actuation, which is a dry needling technique used to stimulate blood flow and encourage collagen production, so improving the appearance and texture of scars. So where scars are thickened and profound, this can help to soften the texture and make them appear more subtle. And the picture at the bottom there shows a before and after picture of the MCA treatment. So as you can see, immediately after the treatment, the scar is accentuated in red. However, this will subside after several days. So as I mentioned before, the effects on a patient's well-being post-mastectomy can be significant. However, medical tattooing can assist recovery. It can improve an individual's mental health, their appearance and body image, their self-esteem and emotional well-being. And it's very much what you were saying earlier, Cassie. As a result, this can increase confidence and simultaneously complement their personal relationships with family and partners. And the feedback from patients that I have had has been indisputable, and it corroborates the need for the service. Not only does the patient benefit, but so too does the medical tattooist. It offers job satisfaction, knowing I can offer a valuable service that is in demand and it's greatly appreciated. It provides an opportunity to engage with patients throughout different stages of care, often encountering the same patients in mammography as I have done in tattooing. And I've extended my role as a radiographer and acquired a specialist skill, which, having previously been carried out by the breast surgeons, has generated a closer interprofessional relationship between surgeons and mammographers. We work closely to manage patient lists, and it's undoubtedly reduced the possibility of cancelled procedures due to surgical prioritisation. So to summarise, radiography can open so many doors and lead to opportunities that may seem out of our remit. The qualities we possess as medical professionals can extend to roles which are uncharacteristic to our profession and may seem unattainable. However, dedication and persistence can prevail.
Thank you, Aideen. That was amazing. Very interesting presentation. Thank you.
Thank you.
So I'm just going to pass it over here to Noelle. She'll summarize everything.
Yeah, lovely everybody. It's always great to have technical glitches, and well done for recovering so well, Aideen. Thank you. I know it's a very interesting role that Aideen's doing, and the work she's done is really complementary to her work outside of the hospital. So yeah, it's great to present it on such a platform. So well done, Aideen. So in just to finalize really, we're going to pop in the chat here if we can. Paula, can we put in the feedback link for feedback from today's webinar? It'd be really valuable if people could just engage with that, just so we can develop and improve the webinars going forward. Our next webinar will take place on the 28th of October, and we're really excited to announce that this will be AI themed, with a number of outstanding speakers already lined up. So we're really, really looking forward to that. Our next newsletter will be released in June, and work is already underway developing this. So we welcome anyone input from across our members. Please invite and share what is happening in your area, any research studies, awards, success stories, and learning points that we can really share on the newsletter. That will be shared amongst our email circulars, and also on the NHS Futures website. And then finally, I thought it was a good opportunity to mention Symposium Mammographicum that's happening in Bournemouth in July this year. I'm sure many of you are hopefully in attendance or hoping to attend. The BISIG committee have had a poster accepted, and we thought this would be a wonderful opportunity to possibly meet members in person for the first time. So if you are attending, please join us at the welcome reception from 5 to 7 p.m. on Wednesday, the 9th of July, at the welcome reception. And the posters will be on display, so we'd encourage you maybe to just keep an eye out for the BISIG poster. I know I'll hopefully be there along with my committee members, and we'll be able to maybe have a glass of wine. I know they always have some sort of beverage on standby, to have good discussion about the other posters on display, but also to meet in person. So that would be fantastic if you are attending. So that's really all. Please, as I say, I'm being muted. People have had enough of me. Yeah, please interact with that Microsoft form. It'll really be helpful for the development. And really thank you for your time, and apologies for going over by half an hour. But I think the speakers today, they were such a high caliber, and it's fantastic to get engagement and to have their time. So I really thank the speakers for attending this evening, and thank you for joining and sharing your evening with us. I'm just looking at the messages. Thank you so much for all the positive feedback. And as I say, we'll see you next time if not in Bournemouth, we'll see you in October for a really interesting artificial intelligence discussion. Thank you, everybody.
Thanks, Noelle. That was great. Thank you. Bye.
Thank you.
Bye.
Bye.
Thank you.
Bye.
Bye. Thanks, Noelle.
Thanks, everyone.
Coco, you've been watching now. Let's talk about watching. Let's go.